Now we're moving on into the surgery section. That's the largest section of the CPT book and the most complex. I do want to announce I'm hopeful that December, that first week in December, our very last class, we're going to have a guest come and join us in the online classroom. And she is an extensive medical coder, has extensive work history in medical coding, working remote. She currently is over the MIT program in Owensboro. So she's going to come and talk about career aspects. So this is a good time if you have questions. It's just going to be an open dialogue. She's going to tell you what to expect working out in the field. So that's something I'm looking forward to, that first Thursday in December. And again, that's our very last class. And we are going over chapter 30 and 31 in week 13. So there are some good videos here. Laparoscopic surgery and how it's done. A lot of things are done with the laparoscope or a scope inserted in the abdomen. Appendectomies, for example. Surgical debridement of a wound. We're going to talk about some of that with the integumentary system procedures today. Spinal fusion and arthrodesis procedure. That is something we get into in advanced coding. That's fusion. A fusion of bones. So spinal fusions are common. It can be done in the ankles and wrists as well. So when we get into these procedures, especially going into advanced coding, we have to do some research to visualize the procedure, to know what it entails. And then you will have a better idea of how to code it. So, and it gets complex. Spinal fusions can be complex. You've got the code for fusing the bones together. If they have to do anything with the spinal cord, that could be a different code added on that. There could be instrumentation used or screws put in on the spine to hold something in place, or metal plates are input on that fusion to fuse it together nice and well. So these are different add-on codes. So this is just to encourage you to get started on that research, because it's fascinating. I mean, I love to learn about how these different procedures are handled. So that's one of the things I like about CPT coding. And we're going to delve into this much more extensively next semester. We're just doing a very brief introduction right now. Next year, we're going to be going over each section specifically. So we're going to talk about integumentary system today, and that's pretty extensive, complicated section. So I don't want you to get discouraged that these codes or it's going to feel pretty overwhelming, and that's fine. I mean, that's going to be normal. We're just going to take this, we're going to ease into it. So I don't want you to feel overwhelmed like, oh, no, I don't know if I can do this. We're going to get lots of practice. So the surgery section is, if you go to your table of contents at the very front of your book, I always refer back to table of contents. We want to find where the surgery section begins, so you can turn to that. So it's after anesthesia. If you go to your table of contents, again, at the beginning of the book, the very beginning of the book, get your CPT book out. We're going to do some hands-on. And when we start on this table of contents, we have introduction, illustrated anatomical procedure review, evaluation and management services guidelines, evaluation and management, which we looked at last week, anesthesia guidelines and anesthesia, we looked at that last week. The next section after anesthesia is surgery, so it starts with surgery guidelines and then the surgery section itself. So the different headings, it's like anesthesia based on anatomy. So we start body systems. So we have the integumentary system, musculoskeletal system, which is the largest section of the surgery, respiratory system, cardiovascular, hemic and lymphatic, mediastinine, digestive, urinary. It's just as beneficial to know how these sections are in your book, because you can turn to these directly sometimes and find your code easier than looking it up in the index. So once you get familiar with the layout, you may find you prefer this method to actually go to the book section itself to review where you can find your specific codes. So we're going to be doing a focus on integumentary system. So let's turn to that first code in that section, just so we have a place that we're going to jump off. So integumentary system starts with code 10030, if you want to turn to that in your book. So I'm going to have us get us here as our starting point. There is a few other things I wanted to talk about with procedures. So the different types of procedures, there's prophylactic, diagnostic, and therapeutic. Prophylactic is a surgery to prevent a condition from happening. So mastectomies are real common for this. If you test for the BRCA gene, BRCA1, BRCA2, you're more susceptible maybe to breast cancer. Some people opt to go ahead and do this, or maybe have a hysterectomy to prevent that cancer from occurring. A diagnostic test is done so a physician can confirm a condition. So there's usually some symptoms that have to go along to support this procedure to do a diagnostic test. And a therapeutic procedure is provided to correct or fix a problem, like a hip replacement. These are 3 different codes. We're not going to turn to these, but this is just to show you the difference in the description. Prophylactic treatment of a femur, pinning, plating, or wiring. Laparoscopy abdomen that collects specimens. And laparoscopy surgical ablation of renal cysts. It's a complete destruction of kidney cysts. Looking at the different approaches for surgery, we mentioned scope or laparoscopy. Scope's minimally invasive, usually goes in by a tiny incision, which is different from a full open procedure, and you can see it maybe documented in the operative reports. It'll say open procedure versus a scope. Sometimes a scope procedure has to convert to an open procedure, so you only bill for that open procedure code. So a lot of procedures can be non-invasive. Example here is as shave biopsy. So that doesn't draw blood. That's pretty routine. Minimally invasive procedures are becoming more and more available. So it's nice that we don't have to get completely opened up to have our appendix removed. We can do that with the scope. Percutaneous approach is instruments inserted into the body by puncturing the skin. So an example is a needle biopsy. Other surgical approaches comes from the natural openings or orifices of the body. Colonoscopy is a great example of that. Esophagoscopy is from the other end. So scopes can be through a natural or artificial opening. And then an open procedure is fully invasive, and the surgeon cuts the body open to access the body parts and organs. So here's another example of approaches. We've got 3 CPT codes on a hysterectomy. So this first one, 58262, is a vaginal hysterectomy. So that's a natural opening, so they want to avoid doing a surgical opening through the abdomen. So that's captured with code 58262. Now it can also be done laparoscopically, like 58542. So that is using the scope. Or it could be a full open procedure like 58150, total abdominal hysterectomy. Everything is removed. All right, so some of the things we talk about in a surgical package, usually a code has a global days assigned to it. And we go over this in medical insurance class. You can actually get on CMS and search different codes in the CPT book and see what kind of global days they have. Some of them don't have any. Some of them have 10 days if they're minor procedures. Some of them are 90 days. So that means any and all follow-up pertaining to that procedure, if it's a 90-day window, is covered, is already paid for. So you don't bill for any of the follow-up that you do in that time frame. So items in the surgical package can include the evaluation of management, for the decision to have surgery. That's covered when they bill for the surgery. Usually local or topical anesthesia, the operation itself, immediate postoperative care, follow-up care, and supplies provided in a physician's office. The biggest thing is knowing what the days are, the global surgery days of a procedure. And like I said, CMS, that usually sets the standard for our insurances. They have their own Excel spreadsheets that you can download to find a code and see what its global day is. Things not included in the surgical package includes diagnostic tests and procedures to confirm the medical necessity or need to have a surgery. That can be coded separate. Postoperative therapies. These are immunosuppressive therapy, maybe after an organ transplant and having chemotherapy with surgery to remove a malignancy. So this is talking about modifier 58. If a more comprehensive version of an original procedure is performed, or is it performed in stages, this modifier is captured on a code to explain that. So it's not the second procedure as it ties into the treatment of whatever the ailment is. The second, more extensive procedure would not be coded separately with its own surgical package. It is not an extension of the first procedure. So staged or related procedure by the same physician during a postoperative period. Let's look at the example here. Where do these mastectomy codes come from? The doctor performed a lumpectomy on Sandra's left breast. The biopsy of the tissue removed during the lumpectomy showed a malignancy has spread throughout the breast. The doctor takes Sandra back into the OR for a simple, complete mastectomy. The second code for the mastectomy is appended with modifier 28 or modifier 58, as it is building off of the initial lumpectomy to treat the malignancy. Other items not included in the surgical package. Postoperative complications that require additional surgery. So complications can be explained with another modifier. Sometimes repeat procedures have to be done. There's a modifier for that. Like a revision of a procedure, like a patient that has a hip replacement, maybe they fall and they injure that replacement during their accident and they have to have the same procedure done again. There's a modifier that captures that. So 76 and 78, repeat procedure by the same physician, like my example previous of the hip replacement. 78, unplanned return to the operating procedure room by the same physician for a related procedure during the postoperative period. 58 is in stages. So they tie together with treatment of a, and this is common in the digestive system as well. If you find, like for the example, we had the lumpectomy to treat the malignancy, and it spread throughout the entire breast, so the mastectomy was then necessary. So it was in stages, that treatment. So modifiers 76 and 78. Let's look at an example for 76. Mary Ann burned her left forearm catching a flaming baton during cheerleading practice. There's some external cause codes. 5 days ago, the doctor applied a skin allograft to the burned area. She's admitted today because the graft is not healing properly, so he's going to apply a new graft. So that was modifier 76, repeat procedure by the same physician. Just having the exact same procedure done.
I assume there's like a time frame on that. one or not? And like if you have a hernia and it rips a year later,
that's out of the global package. Yeah, yeah.
So the 76 is only when you're within.
Yes, yes. So the 76, 78 is when you're within the specific package of a procedure. Modifier 78, we have example 1, a colon resection was performed on May 26. Complications occurred the same date, and the patient was returned to the OR to reopen the abdomen to control the bleeding. So that has the 78. Unplanned return with a complication of the procedure. Example 2, we have a right cataract extraction performed on May 1st. On June 30th, within the post-op period, a laser capsulotomy was performed on the right eye. So this is unplanned return to the operating room following initial procedure for related. So it's related. It's not the same exact procedure. It's related to the cataract extraction. There's also 77, repeat procedure by another physician or a different physician. That's somebody that didn't do the initial procedure. So the example, Joseph was stabbed in the chest during a fight. Dr. Sanger performed a complex repair of a 6-centimeter laceration of the chest. The next day, Dr. Sanger left for a conference. The guy who stabbed Joseph showed up at the hospital, and Joseph got up out of bed against doctor's orders and engaged in another fight, ripping open his stitches. Dr. Addison, filling in for the previous doctor, took Joseph back to the OR to redo his repair. So that is captured with that modifier 77.
That's only if they're doing the exact same procedure.
With a different physician. So we did talk about the global periods. So the examples, doctor performed a diagnostic flexible esophagoscopy on April 5th. The global day of this procedure would be April 15th, so it's not a very invasive procedure. It's getting a 10-day global period. So anything related to that procedure is not billed because it's a part of, if you're doing a follow-up. If it's something if you're doing something totally different on the patient, they had this esophagoscopy and they're coming in with a different complaint within that window, there is a modifier to explain that it's an unrelated condition that the provider is treating. The other example, Dr. Frampton had a patient to confirm arrangements and answer any last-minute questions of her intestinal transplant surgery. On February 5th, Dr. Frampton performed the surgery. The last day of the postoperative period is May 5th, so this is a more extensive procedure. It's getting a 90-day global window. So after May 5th, anything related to that procedure, should it happen to come up, can be billed. And I know this is all complicated, so this is just a slow introduction. We're not going to be working with these types of scenarios until advanced coding. But now let's look at the integumentary system. This one's hard. This section's hard. There's a lot of math. There's a lot of guidelines. So we should be after code 10030 to begin. Oops. So let's get to that code if you haven't already. So turn to the first page. Now your all CPT book may look different from mine. Some of you get that hardback cover. I have the spiral bound, so this is just how it is. So I got a shot of what I'm looking at in my book here and what you're likely looking at. So we have that code 10030. It is, we see the integumentary system there. We are looking at skin, subcutaneous, and accessory structures. And we have the first category, introduction and removal. Code 10030 is for image-guided fluid collection drainage by catheter of an abscess, hematoma, seroma, or lymphocele or cyst. of the soft tissue, the extremity, abdominal wall, or neck that's percutaneous or through the skin. Underneath of that code, we have a note in parentheses, report 10030 for each individual collection drained with a separate catheter. And then do not report 10030 in conjunction with the 700 codes listed there that comes from the radiology section. So if we go back at the description 10030, it says image guided. So it's using some kind of radiological substance to visualize. So you wouldn't, it's what that's telling you is you don't bill that separately with the image guiding. That code includes that feature. So that's our first code of this section. The next section that you'll see starts with debridement on the next page. This starts with code 11000. It does have a percentage of body surface that's estimated up to 10%. We looked at some charts when we talk about burn codes. The rule of nines, like a full arm, I think, is maybe 18%. And if it's upper versus the forearm, it could be half of that. And then there's an arrow for each additional surface of the body that's treated. So a debridement, when you get a wound, like let's say maybe I get on a motorcycle accident and I skid across the gravel road and I got gravel stuck in my wound and all these outside foreign items, and it needs to be cleaned. So it's cleaning debris, basically. Debridement is cleaning out debris of a wound. So the first one was for eczematous or affected skin, 11000. 11004 includes skin, subcutaneous tissue, muscle, and fascia. The fascia is deep in the body, and that's what the muscle attaches to the bone with, is that fascia layer. So that's our debridement section. If we go over to the next page, starting at 11055, we have paring or cutting. These are pretty straightforward, not too bad on these. Just 3 codes there, and it's based on the first lesion and then goes up to 2 to 4 or more than 4. Removal of skin tags. That starts with code 11200. I believe you're going to see this on the exam, but that's okay. These are easy. So this code 11200, removal of skin tags, up to 15 lesions. And then we see over here an add-on code for this section, 11201. Each additional 10 lesions or part thereof. So if I had 18 lesions, I could still code the first code 11200 and then add the add-on code. So that's capturing the extra work that I'm doing. So we're getting reimbursed. Next, we're getting into excisions of lesions. So this is where we have to do some of the math. And what the book shows, the excision of lesions are based on benign or malignant. So you do need a pathology report. I know my friend that codes in wound care for King's Daughters, she always waits for that pathology report to confirm what the lesion is. So that is different sections of this book to bill it. With lesions, you have the size of the lesion itself that's being excised, and then you have the margins that are around it. So there's a pretty easy formula for us to capture that. So you don't want to just stick with the lesion size itself. They usually have to cut around it a certain area to make sure it is fully excised and removed. So there's probably some healthy tissue outside of it that's going to be clipped along the way to make sure it is fully removed. And we're going to look at some examples with these types of codes. But the first one we see is for excision of benign lesions. And then you see we have these guidelines here. It says excision is defined as full thickness, removal through the dermis, and includes a simple closure when performed. I'm just going to highlight here in my, let me see if I can get me a shape going here. So it includes a simple closure, because we're going to talk about closures as well. So this code is what it's saying. If it's just a simple closure, straightforward, you don't bill for that separately. If it's intermediate or complex closure, you can, and we're going to talk about what those are. And so this is where the guidelines are for CPT. They're throughout the section of our book. We go on to the next section, excision of malignant lesions. And these categories are going to follow each anatomical system. When we get to musculoskeletal, there's going to be a category for excision. There's going to be a category for fracture repairs. So obviously that's unique for that code set. There's going to be codes for introduction, doing an injection, taking biopsies. So these are going to have similar organization. But our next section is for excision of malignant lesions. So again, we have to know what the nature of the lesion is, if it's benign or malignant. Moving on, if we go to 11719, we see nails. So our nails are a part of the integumentary system. So we've got debridement, trimming, and avulsion. Moving on, we got pilonidal cysts. Paula, that makes me think of you. So Paula has dealt with this pilonidal cyst with a family member. So this is common procedure. So when you go over to your next page, starting with code 11770, you have the excision of the pilonidal cyst, where if it's simple, extensive, or complicated. If you were working in this area, you would have a good understanding of the procedures and what would make them extensive or complicated. When we code these scenarios, it's gonna specify for us, so we don't have to do this guesswork. All right, now we're getting into repairs. That starts on section 12001. So we start with the simple section. So we had our example of the guy that was in the ER and he got in a fight and he opened up his wounds again. That was a repair that was done to close up that wound. So we have in the book, when we start with code 12001, this page right here shows the examples of a repair, the guidelines for repairs. So it has a sample definition of a simple repair, an intermediate, or a complex repair. So a simple repair is just one layer. It's a one and done. An intermediate repair is layered. That's your key word, layered. Layers of the skin have to be closed to treat it. And then a complex repair includes it's more than a layered closure. You have scar revision and debridement, like we discussed earlier, that goes along with closing up that wound. So our book tells us specifically what these definitions are. And we start with the simple section. It goes on into intermediate with code 12031. And then lastly, we have complex repairs starting at 13100. All right, the next page over begins tissue transfers and skin replacement surgeries. So this starts with code 14000. So we have the body site on that code, the trunk, and a defect of 10 square centimeters or less. So that's going to be stated by your physician, how much of the area was treated in square centimeters. Let's see, our next code set, I skipped ahead here, 15865. So I'm skipping over the skin replacement, skin transfer, tissue transfer section. I don't want to spend a whole lot of time. We're going to be looking at this more in depth in the advanced class. The next section gets into pressure ulcers. That starts with code 15920. And these codes are specific for anatomy. So the first one, 15920, excision of coccygeal pressure ulcer. That's the coccyx, the tailbone area. All right, I'm going to move on to another section called destruction. It's actually on the next page over from pressure ulcers. That same page has treatment for burns as well. Destruction is using a method, electrosurgery, cryosurgery, or freezing, laser, or chemical treatment. It is completely destroying, like it says, destroying a lesion, but it's not excising it. So this is destruction for benign or pre-malignant lesions. Pre-malignant, not malignant. And then our next section is for destruction of malignant lesions, starting with code 17260. And on that same page with destruction, malignant lesions, again 17260, we see Mohs micrographic surgery. So this is a specific type of surgery where a physician that excises lesions also is a pathologist, and he tests those lesions. And it's done in stages. They excise a little bit at a time and test the tissue samples until it's completely eradicated. So again, that's where a surgeon is a surgeon and a pathologist both combined. That's in a more extensive type of work, more extensive type of reimbursement. And then towards our last section of the book, we have procedures of the breast. So breast is mostly skin, made up of skin and the integumentary system. So this includes biopsies for the breast. In this section, we have biopsies, we have mastectomies, and reconstruction procedures. And that's our very last section. Mohs, M-O-H-S, Mohs micrographic surgery. All right, we're going to look at our first coding scenario. Ethan, a 73 male, came to get rid of some skin tags on his left cheek. Oh, this is an easy one. Hallelujah. We can do this one. All right, so Dr. Greenberg removed 9 tags. We just looked at our section for skin tags. If you wanted to turn to that section directly, you can. There's only 2 codes in it. But let's say we're going to go to the index. And we're going to look up the word tag. And again, our index is in the very back of the CPT book. So when we look at tag, it's actually going to say C, skin tags. Just like I have up here on the screen. So we're getting a cross-reference. It is telling us another locale we need to go to. So we need to look up skin. And underneath the category for skin, we'll find an entry for tags. And when we get to that section, we go look up skin and then tags. We'll see removal. And that gives us code 11200 or 11201. So now our next step is to turn to these codes in our book to review. So the doctor removed 9 tags. So looking at code description 11200, it describes removal of skin tags up to 15 lesions. 11201 has a plus sign in front of it, meaning it's an add-on code, and it's never used alone. I've got a typo there. Never used along the way. That's never used alone. So this is an easy one. Our case study is coded with 11200. I like that one. That's the easiest it gets in the integumentary system. When a physician removes a lesion from the patient, you code the excision of each lesion separately. So that's just a highlight of a guideline. Each lesion is a separate entity. Find the guidelines for excision of benign lesions. Let's go to code. It precedes code 11400. And this is the page that I have it on. This is what it will look like for you. So you'll find code 11400 and then turn maybe to the page behind it to where you pull up just what I have on my screen. It says excision of benign lesions. And we did look at this. Excision, the second paragraph, is defined as full thickness or through the dermis, removal of a lesion, including margins, and includes a simple closure when performed. That means if it's a more extensive closure or complex closure, we can bill that separately. We can add that code on separately. To correctly measure what was excised, you have to look at the dimensions of the lesion itself and give it a proper margin, which is what the guidelines section are illustrating. That's likely going to be given to you by the physician, and that's really nice when we get that. When it already says the lesion is 3 by 5 centimeters, including the margins. But let's just say for whatever reason we don't have a margin included, we're going to do an example of how we can calculate that. Okay, so I thought it'd be nice to put my PowerPoint all up. Now the text is too large. To correctly measure what was excised, add the size of the lesion to the size of the margin doubled. It's not going to make sense until we look at an example. So this is the same page we were looking at, and they show these lesions with their margins around them. Okay? And this is the formula. The coded size of the lesion is the largest size of the lesion plus the size of the margins times 2. And if you're like me, you can't hear, I'm just hearing math like that, it wouldn't make any sense. Let's look at this example. A lesion is 3 by 1 centimeters in size with 0.2 margins. So the lesion, we go by that largest size of it, the 3, plus, in our parentheses, we have, did it tell us our margins there? 0.2 margins. So we put our margins there and we multiply it by 4 because we're covering the whole perimeter of that lesion. So 0.2 times 2 is 4, okay? So the next part of our formula, we have that largest size of the lesion plus 0.4. So that gives us a total of 3.4 centimeters. That's the size of our lesion. So that's our formula, the largest size of the lesion plus the margins times 2. We're covering the full perimeter. Let's look at our first example here. The doctor excised a lesion that was measured 2 by 1 centimeters with 0.2 centimeters margins all around, and the lesion was benign. All right, so the doctor excised a lesion measuring 2 by 1 centimeters with 0.2 margins all around, and it's benign. So starting with our formula here, we've got the largest size of the lesion, or the 2, plus the margins times 2. So we've got the largest size of this lesion is 2 by 1 centimeter. So our largest size is 2. We had 0.2 centimeter margins. So now we go to the second part where we're starting to fill in our formula. Largest size of the lesion, 2 centimeters, plus the margins are 0.2 times 2. So margins times 2. And then when we get 0.2 multiplied by 2, it's 0.4. So when we add those together, 2.4 centimeters is the coded size of a benign lesion. All right, so the coded size is 2.4 centimeters. Now, we could go to the index and then find excision and then lesion and skin. But let's go ahead and turn to this section in our book. It's a benign lesion. We're already at that section, okay? So we're going to start with code 11400. So this is our excision of benign lesions section. We're going to turn to this section, and it was from the skin of Benita's neck that it came from. So what I've got here, I've just went ahead and did the full, if we went to the index and it gives us a code range, that's what we're seeing here. But we're going to go ahead and do code 11400 to review, okay? And it was on the skin of the neck. So we know our coded size of the lesion is 2.4 centimeters. And it was on the neck anatomical site. So 11400 is the trunk, arms, or legs. So we have the trunk, arms, or legs. And we have our lesion came from the neck. So now let's move to code 11420 and review its description. So this is excision of benign tumor of the scalp, neck, hands, feet, or genitalia. And 11420 is for 0.5 centimeters or less. Now our coded size is 2.4 centimeters. So how big is the lesion with the margins? 2.4 centimeters. It's benign. It's on the neck. So reviewing the codes from 11420 to 11426, which one is correct? So we had a 2.4 centimeter lesion. So our scenario here is 11423. That is our code for an excision of a benign lesion that's 2.4 centimeters total. And we're done with that. It's a little bit complicated. These are very hard. This starts with the hardest section of the book. This chapter is without a doubt the hardest. We're going to talk a little bit about modifier 22. So a physician's notes may indicate excision of a lesion was complicated or unusual in some way. So modifier 22 added, and you need an extensive report explaining why it's complicated to deserve that extra reimbursement for your time, is why that exists. Although I have heard this referred to as the Superman modifier. meaning that you'd have to be Superman to get insurance to pay for it. So you would have to have very extensive documentation to back up why you would need that extra reimbursement. Just another tip, modifiers can be found in Appendix A in the CPT book at the very back. There's no index on how to look up these modifiers. We only get to know them through practice in class. All right, let's look at another case study. Dr. Simmons excised a lesion measuring 3.1 by 3 centimeters with 0.3 margins. It was from his left forearm. Due to the lesion's proximity to the wrist and bone, it took more time and more exactness than a typical procedure. So this is hinting at the modifier 22. That's why we're covering it. And pathology confirmed that the lesion was benign. All right, so we're still in our same section. We just need to get the final size of our lesion. So we had a 3.1 by 3 centimeter lesion with 0.3 margins. We go by the largest size of that lesion, the 3.1, plus the margins times 2, as I show in this part of the formula right here. So the margins times 2, 0.3 times 2 is 0.6. So we come down here, we see the largest size of the lesion, 3.1 plus 0.6 margins. That gives us 3.7 centimeters. So our coded lesion size is 3.7 centimeters. It's a benign lesion and it's on the forearm. Let's go back to where our section starts at 11400. And this is a 3.7 centimeter lesion on the forearm. So we're going to look at codes 11400 to 11406. Lesion's benign, it's 3.7 centimeters with its margin. We're starting at code 11400. So these are just steps I'm walking through to get us there. So we should have, for this case study, code 11404. So this is a benign lesion from the arm, and the code description says arms, so it could be one or both. And it's 3.7 centimeters. So that is our perfect code. And then lastly, because of the excessiveness of the procedure, it's given that modifier 22. So again, this is just as a example, as a case study. We don't go into this type of coding right off the bat from day one, knowing how to be successful or knowing all of the guidelines. It's just going to take a lot of practice, so don't feel overwhelmed. It's not possible to memorize all modifiers in the duration of the class, so don't worry about that. I'll tell you specifically what modifiers you would need to know, like if we're doing exams. All right, now we're going to look at closures. So closures start with, it's also known as a repair. They start with codes 12001. Repair simple. So take a moment to turn to that section. So there is a guideline if you have multiple repairs on the same body site that are the same extensiveness, you add them all together. So let's say like on my right forearm, I have 3 cuts or lacerations, and they repair all 3. They're going to add up the size of those lacerations. And let's say they were all an intermediate repair. They're all the same type of repair on the same location of the body. You can add all those together. Let's see. Let's code it. All right. Quentin is got into a bar fight. He has wounds on his hand and arm. The doctor performed an intermediate repair of a 5 by 2 centimeter wound and a 3 by 1 centimeter wound on Quentin's right hand, and a simple repair to a 3.2 by 1 centimeter wound on his right forearm. So we've got 2 intermediate repairs on the right hand and 1 simple repair on the forearm. So the repairs needed for the hand are both on the same location. They are both intermediate. So we can add these together. All right, so this is the breakdown. Intermediate repair of 5 centimeter wound and 3.1 by 1 centimeter wound on the hand. And you add the longest measurements of those together. And then a simple repair on the forearm. All right, so we are going to look at first the intermediate repair. We had a 5 by 2 centimeter wound plus a 3.1 by 1.1 centimeter wound, and I've got in parentheses here their largest size, so 5 and 3.1. We add the largest size of those together. That gives us 8.1 centimeters that was repaired on the right hand, and these are intermediate. So we know that. We know we're going to get an intermediate repair on the hand for 8.1 centimeters. And we're not going to use directional modifiers on these because these code descriptions say hands, feet. So it's indicating one or both. We wouldn't need a modifier. All right, so looking up for this code, we have an intermediate repair. We want to go to 12031. That's where the code section begins. For intermediate repairs, it was on the right hand. We had 8.1 centimeters repaired total. So starting with code 12031, repair intermediate wounds of scalp, axillate, trunk, and or extremities, excluding hands or feet. We know specifically this was the patient's hand, his right hand. Intermediate repair was done on right hand, so we cannot use this code. Let's jump to code 12041. Repair intermediate wounds of neck, hands, feet, and or external genitalia, 2.5 centimeters or less. What was the sum of repairs for the right hand? It was 8.1 centimeters. So that gives us code 12044. So intermediate repair of 2 wounds that were added together on the right hand. Now let's go find the simple repair. The simple repair was a 3.2 by 1 centimeter wound on the right forearm. So we take the largest size of that measurement. It was 3.2 centimeters. We're going to backtrack now to find the simple repair heading. That's going to start with code 12001. And this was a repair of the right forearm, simple 3.2 centimeters. So we begin our review with 12001. So that code is simple repair of scalp, neck, axillate, external genitalia, trunk, and or extremities, arms and legs. And how big was it? 3.2 centimeters. Repair was performed on the forearm. And the code mentions extremities, which are the arms and legs. What was the size? It was 3.2 centimeters. So that's going to give us our second code. So for our case study that we just looked at, we have two codes, 12044 and 12002. Now, these two codes, one thing I will point out, the 12044 is the most extensive, so it would be listed on the claim first. It's going to get the full highest reimbursement. So you wouldn't want to list the intermediate or the simple repair first. The most extensive, most expensive is listed first. So that's why the 12044 is our first code. It's the intermediate repair. And then we have the code for the simple repair. All right, this is different ways to destroy a lesion. We already kind of talked about that. The destruction section, we've already looked at that. Turn to code 17000. Review the codes and descriptions. We're going to skip that. We talked about Mohs microsurgery. Now we can move on just a little bit to the musculoskeletal system. So this includes procedures on bones, ligaments, cartilage, muscles, and tendons. It is the largest section of the surgery section. We can begin review by going to code 20100. Go ahead and turn to there. Let's go to 20100. And it starts with wound exploration. So this code belongs to wound exploration 20100. Exploration of a penetrating wound, so that's a knife or a gun or whatever foreign object. Gunshot, stab wound. So that's our first section. Then we go into excision next. Each anatomical category has similar headings, so like excision, introduction, incision. So excision, we get into some biopsies of the muscle. Just some tips for procedures with the musculoskeletal system. Fractures come out of here. So fractures can be open and closed, and treatment can be open and closed. So that's a big difference we need to be familiar with. So closed treatment means they are able to manipulate the bone back into place in the office. He doesn't have to open you up. Open treatment is they have to do a complete incision, open up the bone, visualize it. They may have to do some pinning or putting some metal plates in. So there can be open and closed fractures, and they can have open and closed treatment. An open fracture is protruding. Part of the fracture is protruding from the body. So we'll go over all these slides. We just talked about that. Arthrodesis. This is the fusion surgery. And this is, I would say maybe watch the videos over this procedure. That's better than me just telling you about it. Let's see. This is more about fractures. Let's go into our code. Benjamin, 17-year-old male, fractured the shaft of his tibia. And the orthopedist is able to use a percutaneous fixation using pins. So he put pins through the skin to fix that bone right to its place. So hopefully it will heal nice and normally. So we are looking for the procedure code for a percutaneous fixation using pins. So let's go to our index and look up fracture. And once you find fracture, we want to find the tibia bone that's under the heading of fracture. And from here, we would find percutaneous fixation under tibia. Luckily, that gives us one code. So they should give us 27556. So we go to the index, fracture, tibia, and percutaneous fixation. 27556. So now we go to code 27556 to review its description.
What's the difference in like, okay, this outlet fixation and then tibia, and it doesn't have that code, and I see that you're, so how are we supposed to know like which one to go to, or just the practice?
You see,
Outlet fixation, tibia, and it's got like a half a dozen codes in there, but it doesn't have the one that you just said, which I see under the fracture.
yes. There could be different types of fixations. Where it's specified percutaneous, it's through the skin.
Fracture rather than fixation.
Yeah. You would look up the code descriptions, and then probably it wouldn't fit what, like the actual term percutaneous. Let's take that first one, 27535. So the first code, 27535, open treatment of tibial fracture. So that in itself, we didn't have an open treatment. It wasn't incised or opened up. So you would have to review all the code descriptions. Yeah, and then once you find, you
As far as knowing which one to get first, you know, fracture or fixation.
yeah, yes. You'd want to know different ways to find what you're looking for in your index. So let's see. So, whoops. So this code was 27556. All right, let's look at another coding case study. Gary's 39-year-old. The doctor performed a nasal sinus diagnostic endoscopy via the inferior meatus, so opening, with a maxillary sinusoscopy. Quite a bit of scope procedures. All right, so a nasal sinus diagnostic endoscopy via the inferior meatus with a maxillary sinusoscopy. All right, let's go to our index and look up endoscopy. And then from endoscopy, we want to find sinuses. And from sinuses, we'll see a category for diagnostic. And that gives us two different codes. So I'm going to leave this on the screen just for a moment to give you a time to find this in your index. So now we go back to codes 31233 and 31235 to look up their descriptions. So now we're getting into the respiratory system. So 31233. So reviewing those codes, I'll give you a moment to look them up and review. So for our scenario, 31233 fits perfect. It is a nasal sinus endoscopy diagnostic with maxillary sinusoscopy via the inferior meatus. That matches perfectly with our documentation. The next code was 31235 is with a sphenoid sinusoscopy, which is not mentioned. That was the respiratory system section. The 300 sections also shared with cardiovascular surgery, and that's very complicated. Specifically coronary artery bypass grafts, which I find those fun. They have complex guidelines, but I think it's fun to try to figure it out because you need to know how many grafts. Was it vein grafts used? Was it arterial grafts? Were both used? There's specific veins and arteries that are considered included in a procedure, and others, if you harvest them, they can be billed extra. So this is just some examples on how complex it can be. Digestive system is our next section. So our scope procedures are very heavily featured here, like colonoscopies. Let's see, our next, let's code it. We have a colonoscopy procedure. So Paul came in to see his doctor. He was given verse, so he was given a conscious sedation. Let's see, a 3mm sessile polyp was destroyed using ablation. So we had a colonoscopy procedure, and a polyp was destroyed with ablation. So that's what we're trying to code now. Let's go back to our index. We're going to look up colonoscopy. And then it's going to have a header that says flexible, which all of the codes fall under that. I guess because the tube is flexible, non-flexible doesn't sound very good. But that's just how you're going to see it. It's going to be a rather large category. So we're going to find colonoscopy in our index. And there was an ablation, which is handy because it's at the very top of that index. And what was ablated was a polyp. And that gives us code 45388. So we turn back to this code and review its description. We're going to go back and turn to 45388 directly.
So how do you go to the subheading or go to flexible?
That's just how that covers all the codes.
Okay.
Yeah, they're all going to be under flexible, so there's no other option. So we're going to go back to code 45388 and review its description. And there is also in the colonoscopy index a heading that says through stoma. And that means particularly through an opening, an outside opening, when it says stoma. You probably heard of a colostomy bag. That stoma is the opening to the outside. So that's another approach of the procedure. So 45388, looking up this code. Uh, 45388. Colonoscopy with ablation of tumors, polyps, or lesions, which is our scenario. Okay, I think I have one more coding scenario.
Real quick, the pound sign that's next to that code, is that just because
It's out of sequence, yep. So it does have a number sign beside of it. So what happens is when new codes get introduced, codes that are out of sequence are still, they make sense to be grouped in a certain section rather than moved, it doesn't necessarily follow a numerical order. And that can be kind of frustrating, especially in the pathology section. We see this a lot. But there's usually notations that'll tell you what code range to find it. So yeah, that pound sign just means it's out of sequence. Luckily, it wasn't too hard for us to locate. All right, our last scenario, we have the urinary system, a nephrolithotomy. So we have an incision in the kidney of a kidney stone with complete removal of the calculus, or the stone. That's what it's referred to as. So we have a nephrolithotomy with complete removal of calculus. Now we could potentially go to the urinary section and find the incision category to find this code, but we're going to go to our index and we're going to look up nephrolithotomy. And that gives us code range 50060 to 50075. So now we need to review these codes. We're going to turn to code 50060 to begin reviewing. So 50060 is perfect, nephrotomy, removal of calculus. 50065 is secondary surgical operation. I I'm taking that. I would need to research that. Do a Google search of that code. I would take that as it's a part of another surgical procedure. But we don't have anything in our documentation that lists it's a part of a secondary or a separate procedure. So we can default to 50060. And now we get to our worksheet review. So yes, we had a long class today. Oh gosh, did you guys lose the screen? I must have, maybe I exited out of it. Do you know how long ago that was? Just a few minutes? Okay, good. I must have closed my screen by accident. I'm going to go ahead and stop my recording.